Dr. Viacana, and let me tell you a little bit about Dr. Viacana. Dr. Viacana spoke at our meetings, 12, 15 years ago. He was at different meetings. And then I was in the process of needing a fourth kidney transplant. And he was at a different hospital than what I was registered at. And he said, Lori, you really need to come hear what we're doing at Cedars-Sinai. And I went and made an appointment, and the course of action that he told me I needed, I agreed with him. I switched hospitals from my current hospital. I felt like I was breaking up with a long-term boyfriend when I had to leave the current hospital that I had 2 previous transplants at. And I got that transplant in 2011. They were absolutely right. We have to be our own advocate. And today, Dr. Viacana is an RSN board member, and he's the medical director of the Loma Linda Kidney Transplant Program. So welcome, Dr. Viacana. We're so happy you're here today.
Well, thank you, Lori. Appreciate the introduction. But before, I need to figure out how to share my screen.
Okay.
But yes, thank you. Nice to be here, and nice to follow you, Anne. It's always it's kind of a tough act to follow. As mentioned, I was in LA some time ago. I think a little bit after you donated, maybe about a year after you donated, I joined the group for about 10 years, and then moved further east to the heat out here in the inland area. But yes, yes, it's been many years that we've known each other, Lori. I'm glad that you're thriving and doing well. And I think that was like at the Glendale Library, I think, where we met the first time.
We did. You were always so wonderful to speak for us.
So I was asked, and I'm glad you picked this topic, because sometimes I don't think about it in this way. The question of, the signs that maybe, your transplant is doing well and it's happy and healthy. A lot of times it's, you go to the doctor. As a matter of fact, we are doing clinic at the moment, and I stepped out a little bit between that. But, a lot of times you go to the doc's office, you get your results, you go back in a month or 3 months and so forth. But there are ways, there are signs to know if your kidney is doing well and how to keep it going well. A lot of it really is not much on what we do here in the office. It's more about what's going on at home, controlling things that you can control. We try to do our part as well, but it's like really a lot of factors go into how long a kidney lasts, how well it does, and things like that. So not to be a downer, I'm going to show a couple slides just to show kind of like how long a kidney, can work. There we go. So I hope you can see this okay. I know there's a lot of numbers on it, but I'll kind of distill it. A couple of things that this shows is really how our country performs relative to other areas of the world. New Zealand, Australia, New Zealand in one column, Europe, and then Canada way on the right. And what you're going to notice is that it kind of stratifies things according to what kind of donor you received. So whether it's a deceased donor or a living donor that you just heard about, clearly, and you can see it right there, that the living donors, those that receive a living donor at the 1 and 5 year mark, do way better than those that had to wait all that time that they waited for their kidney. And I'll get into a little bit more into the wait time, but it shows a couple things. Number one, living donor is way superior to just about anything that we could offer on the wait list. Number two, interesting, the US is actually kind of slowly a little bit behind some of these other regions of the world. I'm sure there's different factors that go into that, but it looks like we have a little bit of work to be done, at least in our transplant community. But this is where I'll put in a plug that you just heard about living donation. It really is way superior to just about anything I can offer you on the list. There's a few nuances, but in general, living donor is way superior. Why? Number one, the quality of the kidney is superior. Number two, you don't have to wait as long as you would for a kidney. To give you, I didn't include the data, but typically in our region in Southern California, if you're, blood group O, we'll say, people are waiting anywhere from, 8 years to 11, 12 years for the kidney, minus, of course, their dialysis time. If you're A, it's roughly around 6 to 10, 6 to 11 years. If you're B, roughly the same, 6 to 11. And if you're lucky enough, I guess, to be AB, then you're waiting, 3 or 4 years, maybe up to 6 for your kidney. That's still a long time. Each year on dialysis, as everyone knows here, is not easy. So that's why, and it shows here on this data that living donation, those that receive one, they just do well in pretty much all metrics. Everything you can measure, they do better. So again, it's a plug for living donation. But don't fret if you don't have a living donor. Obviously, there are deceased donor options, and within that, the transplant center can discuss, what options there are. But in general, living donor is the best, and hopefully, you're lucky enough, for those of you that are on dialysis and listening, that you maybe have someone in your midst who is like Anne and can come to the rescue. All right. So what happens when you come to the office, other than waiting forever, the madness of long lines, and seems like everybody has the same appointment time. So what happens? You check your labs, of course, and you go, blood and urine tests. Most people will focus on the actual kidney number. They always focus, who receive a kidney, and some docs as well. What's the creatinine? The lower the creatinine, the better the kidney function. But we focus on a lot of other things as well. And now that everyone, or maybe many people are seeing their labs on their phones now, either via MyChart, which I think a lot of transplant centers are using, and you can see your labs from Quest or LabCorp. You can sometimes see things before I do. So these are the things, but obviously the creatinine is what everybody focus on, and that will give you the GFR. But we also look at the urine. Is there protein? If there is, was that an issue? Is that why someone did receive a kidney transplant in the first place? So then we kind of start looking at that. We look at measure some of the medications that one might be using, and I'll get to that about what some of these meds, tacrolimus or Prograf, cyclosporine. We measure all that. Sugars. Unfortunately, not on purpose, but unfortunately, we do create problems with our medicines. We try to help, but there's certain things that we do induce, and one of them is diabetes. We could actually make someone diabetic with some of the medications that we use, Prograf or tacrolimus in particular. Prednisone always gets the bad rap, but I'll talk about that a little bit later. But those things can exist. We can make high blood pressure worse sometimes with some of the meds as well. And I'll show you a couple slides a little bit later about that and what we can all do together to kind of help blunt that issue. But the bottom line, it's not just the kidney function that we focus on. We focus on other things that over time could actually affect the kidney in a worse way than rejection, actually. One thing I do want to stress is, especially at the beginning, you go to the labs quite a bit the first 3 to 6 months. There's always some fluctuations, and especially the kidney function may fluctuate. And I don't want everyone to think, oh, I'm rejecting, because honestly, for me, that's not what I think of first. When I see fluctuations in kidney function, the first thing I actually think about is, what did I do last time to make it worse? Did I start a new medication? Did I do this? Did I do that? But once I look at that, the Prograf level or cyclosporine level could be the culprit. Hydration is an issue. Urine infections can be common, especially at the beginning. So there's other things that are other than rejection. I just don't want everyone to think that when there are fluctuations in the kidney function that they're all rejecting, because in general, that's not the case. Sometimes it is, but it's more often than not something else, actually, especially early on. Okay. So this next slide is kind of busy as well, but I think that the gist of this, and this came out this year, the gist of it, there's a lot of new tests that are on the market over the last, 4 or 5 years. And it seems to be that every 6 months, there's a new one. And I know, Lori, you get approached quite a bit by folks in this industry who are coming out with the latest test, whether it's blood, whether it's urine. But there are a lot of neat things that are either present already or in development that go beyond just kind of saying how you're doing that day. Like that day, I can tell you the kidney's this. But there's some tests that kind of can tell you what might be brewing or what's around the corner, what's on the horizon. Some things are already, for those of you that are listening that haven't received a transplant, maybe you already had some of these tests already. There's quite a few of them. I'm not going to name them because there's so many of them. But the idea is this, that there's tests that are out there that could help us detect if there's an issue, maybe before it becomes very obvious. A kidney biopsy is really the main way to officially diagnose many things, but there's a lot of things out there that can kind of give us an idea that something's brewing, or that maybe things are actually okay when they don't seem to be okay. And maybe you could back off, maybe doing a biopsy, rushing to do things, freaking out too much, overreacting, depending on some of these other tests. But just want to let everybody know that there are things out there in the pipeline. They've been out there for about 4 or 5 years commercially. More things on the horizon, especially in terms of urine testing. I believe more of that's going to be coming online soon. All right, so back to being kind of a downer. I mentioned, the kidneys. Actually, I mentioned wait lists, how long it lasts, in this area to wait for your kidney. But in general, how long does a kidney last is something that comes up quite a bit, and actually came up about an hour ago here in the clinic. A lot of it depends on the donor and the recipient combination. Obviously a lot goes on there, but a living donor, of course, is superior. Living donors, the average is over 15 years in terms of how long a kidney from a living donor lasts, at least 15 plus. I've seen more, I've seen less, but averages are exactly just that. If you get a kidney from the wait list, there are different options, different types of kidneys. But maybe like if like an older kidney program, those kidneys may last like 8 to 10, a little bit more than that. Maybe a regular kidney from the wait list might last you 10 to 15 years. But again, the living donor is superior to all of that as well. But this is kind of a talk about making sure your kidney is fine, signs that things are going well. But what are things that can derail? And just as I mentioned, not to be a downer, but there's a little delay here, but causes of problems after transplant. And I'm going to focus on the heart. The cardiovascular really is like the big chunk of things. That's really what's gonna derail even a good functioning kidney. It could make it turn south in a quick way. Malignancy is there, but not as much as cardiovascular. I am in the afternoon. For those of you that'll be joining us in about 3 hours, I will be specifically talking about cancer, all those issues regarding, those of you that are on the list that have either had cancer and are waiting because of that, or those of you that had a transplant, how to screen for cancer afterward, or those of you that have been diagnosed with cancer after having a transplant. So that'll be a little bit later, but cardiovascular is a big deal. And within that, just like anything, the typical stuff that affects all of us, whether we've had a transplant or not, is still pertains to someone that did receive a transplant. There's traditional things as well. On the left, high blood pressure. Those of you that smoke, hopefully not many of us on the call today, but there's some nicotine use. Those that have kidney concerns, lipids, diabetes. I'll get into that a little bit more. A little bit less traditional, but actually I'd say more traditional these days is weight issues, bone disease, oxidative stress, which I'm sure a lot of you have heard about, inflammation, and then immunosuppression, which I'll talk a little bit about our medications that we do use that can contribute and make some of these things worse, actually, from that perspective. And then, of course, after the transplant, we just want to make sure that there's no heart failure, and if there is, that it's being managed appropriately. Arrhythmias can happen, especially after surgery. I noticed people can get irregular heartbeats right after the procedure, and then of course, blocked arteries. All those things can happen to someone. Just because you've had a transplant doesn't mean that can't happen. It unfortunately can happen, just like to the rest of us. And these are some of the general risk factors that are out there. And kind of expanding on this slide, the next slide. So how do we manage these things? So way on the left, we kind of, first of all, you have to identify that, which is not, sometimes it's like almost like right in your face. And sometimes it might take me 2 visits to notice something. It's kind of embarrassing, but you're like, oh, wait a minute. I don't think I realized something is off, because we're focusing on the kidney, we're focusing on medications and levels and things like that. But sometimes there's certain things that are like, kind of like, whoa, the sugars are going up, and you're not diabetic, and all of a sudden it looks like you're becoming one. And what are we going to do about that? So, we screen for risk factors. We discuss lifestyle changes, and I'll get to that in a couple slides. Then we personalize medications as much as we can, depending on that. Something that I do sometimes, I will, when I see someone developing like high sugars after surgery, we try to get their steroids down as low as possible, as quickly as possible. I might make another maneuver, switch the Prograf to Cyclosporine. If you do it early enough, sometimes that is helpful. Of course, if you do recognize that there's a problem, then you have to get the cardiologist involved and the rest of the team involved. Nutrition could be a big player in this arena as well. And of course, further research. There's some new medications that are out there that a lot of people are excited about in the heart and kidney world. Something called the SGL2 inhibitors that are out there, that they're kind of all the rage right now in what we do. You'll probably start hearing more and more of that. It's kind of like what maybe about 25, 30 years ago, something called ACE inhibitors or ARBs, when they came on the scene for the heart and kidney. This is kind of that's what's kind of happening right now, but there's more to be seen as time goes on. But bottom line is, first you got to identify it. Sometimes it's right there and it's staring at you, and I don't pick up on it until maybe a couple times. So what to do though? What to do, and this is something, it's not easy to follow, especially it's I can speak for personal experience, being stuck here in the office quite a bit. But bottom line is, diet is something that it doesn't get as much press, doesn't get as much attention. It's always about like, oh, okay, I'll throw on the blood pressure medicine, or I'll start something to lower your sugars. I'll adjust this, I'll adjust that. But really, if you think about it, and I'll show you the data to back it up, is diet is huge. It plays a big role. I think we've all heard of the Mediterranean diet or even the DASH diet. There are some minor differences there. But this slide just shows you how they differ. Mediterranean, has more fibers, more vitamins. The fatty acids are not the medium or long chain fatty acids. They're not processed foods, things of that nature. The Western diet, and I'm guilty, sounds like they just read what I did yesterday. Low fiber, vitamin deficient, a lot of fatty acids, processed foods, sugars, basically that's kind of what we're not supposed to do, but it's the easiest thing to do. Basically, for a Mediterranean diet, basically it's you drink water and red wine. That's mainly water, but they say red wine is okay. The main difference, though, for those that are wondering, between a Mediterranean and a DASH diet, the DASH diet is probably more known in this country. It's meant to really lower your blood pressure. The main difference is I think there's more fish intake in Mediterranean, and a little bit less dairy in the Mediterranean compared to the DASH. And maybe there's some dietitians on the call, they might want to correct me, but that's kind of what we've seen. But bottom line is, diet is huge, and it plays a big role. And I'm going to show you specifically to the transplant world about that. So this just came out, well, I guess last year, I believe a European study, and they were curious. They're like, does adhering to a Mediterranean diet, does it help? Because a lot of times we'll say diet and exercise without really backing up. It's so easy, but it makes sense. But a lot of times we just say that without really the data, the hard data to really show it. This one, it does it nicely, I believe. It studied over 600 patients in Europe who had a kidney for at least a year. They, did interviews and to see if they, stuck to the Mediterranean diet. They followed them up for up to about 5 years. And what they saw, it's pretty impressive, is that yes, kidney failure is less. So basically the way to read this, the hazard ratio is 0.68. That means there's basically like a 32% reduction of kidney failure in those that kind of had a higher Mediterranean scores. And then the kidney function decline, also 32% less decline. And then losing your kidney altogether was 26% less for those that really adhered to a Mediterranean diet as best they could. So the data is actually there. It's quite nice. I'll be a little bit more, the same paper I'm going to show you a couple of slides real quick just to kind of expand on their conclusions. But this is the same publication that I just shared with you. And it basically, the diet score at the bottom from 0 to 9, at the bottom, 9 being the highest, like really adherent. So if you're like in the higher scores, you know, your kidney failure is less, you keep your kidneys longer. That's I hope you could see that pretty evident there. Wanted to throw in a little bit about the DASH diet, just because it is a little bit more common, I think, in this country. Very similar to Mediterranean, the same ideas, of course, more fruits and vegetables, less refined foods, processed foods, but Mediterranean, a little bit more fish, and versus the DASH. But again, this same thing. They showed that those that have a higher DASH score have you know, a lower rate of decline, you know, lower mortality, all those things. I mean, it's sometimes it's you know, it's one thing to say it, but then to kind of back it up with real information, it's pretty impressive when you see it in front of you. So, and then I got this from a publication this year, just kind of showing a kidney recipient, you know, the balanced plate, if you will. And this is something that really, you know, I'm not a dietitian, I'm not an expert at all by any means in nutrition. But that's why it was a nice exercise to kind of go over some of this data. Basically, vegetables and fruit should be at least half your plate, you know, with protein, you know, palm of your, you know, size of your palm, and then whole grains, etc. So I know it's not easy. Actually, when I was reading this, when I was kind of prepping for this week, I was like, wow, how often do I actually do this myself? And the answer is fairly infrequent, unfortunately. So, but yes, the data is there. It's clear. That's why people say it. All right. I think the next, before I go on to non-diet things, so we talked about, you know, diet being important. A lot of things. What about the high-risk foods to avoid? This comes up so. This is so common, and thanks to Lori for recommending that I at least touch up on this, because it does come up. Now, when you get a transplant, the answer to just about anything at the beginning is no. You know, they always say no. Like, can I do this? The answer is no. There is some data to it, and actually some of it's common sense. I try to find certain things in particular. The one thing that comes up a lot is, can I have sushi or like ceviche? And there really isn't like any study, like official study about like, you know, people that half the group did and half the group didn't and stuff like that. There's nothing that I could find in that regard. This is actually from the FDA. And, you know, this is directly from a government website. There is data. There is some data. Some of it may be older, but some of it's common sense. You know, obviously eating raw or undercooked meats is maybe not the best idea. Do you know, and do I know people that have done this after a transplant and they're fine? Yes, I do. But then, you know, just yesterday, a close friend who had a transplant, he tells me how he got salmonella in the summer for, you know, getting, you know, as a gift, he got some cheese from Mexico, you know, then, you know, people can't, you know, they just love that. You know, gifts, of course, are hard to turn down. And of course, things that really are quite tasty can cause a problem. And I looked, sure enough, I was like, salmonella, are you sure? Because I didn't know about this. And I looked in his record in another hospital, and luckily we were linked to them. And sure enough, salmonella, and the state has to be notified, and because that's one of the things that they're there. So I mean, it's better to err on the side of caution. I know people, you know, people that eat certain things after transplant, and sometimes it works out, but sometimes when it doesn't work out, it gets scary in a hurry. So those are the things, basically undercooked foods, unpasteurized dairy products, of course. Those are the big things. So unfortunately, in terms of sushi, that officially the answer is no, at least the classic sushi. All right, let's get a little bit to exercise. Just a couple slides on that. I mentioned diet, of course. You know, this study is actually a little bit older now. It's about 8 years old, but they broke them down into two groups: those that gained weight or body fat, and those that did not gain body fat. So those that basically gain body fat are in the solid black lines with the solid black circles. And they're the ones that had less activity. Their activity score is on the left. So it makes sense. Less activity, worse diet will be a downer in terms of how things go in the future. And then just, I'm going to speed up a little bit, but again, saying the same thing, those that they gained weight, their BMI, actually starts to happen within 3 months. I'd say the majority of the weight that someone gains after transplant, usually like the first 6 months, not so much after, but the first 6 months are huge in terms of weight gain. So again, activity is a big deal. Doesn't seem like it is, but it's very simple. Diet and exercise, even for someone who's had a transplant. It really pertains to all of us. All right, I'm going to switch gears. Vaccines are super hot topic, and near the end, I'm going to wrap up with the COVID vaccine in particular. But I just wanted to throw it out, talking about, keeping your kidney nice and healthy, basically just keeping you yourself healthy overall. And these are the recommended vaccines. It's flu shot season. They were just here in the office a couple of weeks ago. They hunted us down and gave us our flu shot. And some of us will be getting our third booster of COVID soon. And excuse me. So Pneumovax, or the pneumonia shot, every 3 to 5 years, depending on your age. But basically, the flu shot is recommended yearly. For sure, special situations in terms of travel depends on that. On the right, though, I'm going to expand on it. Basically, live vaccines should not be done. I get this question a lot. Can I get this? Can I get that? But there's live vaccines that you should never receive. And this next slide will dive deeper into that list. So basically, there used to be when there was the swine flu about 10 years ago, some of us may have received like the nasal flu vaccine, and that was live. That's actually there. I haven't seen it since, but I remember there was a shortage, so you saw that. So you shouldn't be getting that. Anyone, the MMR, the measles, mumps, rubella, that's the live vaccine. There is a shingles vaccine that was, for a long time, that was live, and it still is, but there's also an alternative to that in the last few years that is not a live vaccine that you can receive for those of you that would like to get protected against shingles after you've already had your transplant. There is a non-live option for that. The flu shot, I'm going to just be a little bit, I get so many excuses about why people don't get the flu shot. This came out this year. SOT means solid organ transplant recipients. So basically, we know that those that have had a transplant, they get influenza, they have an increased risk of pneumonia, kidney basic organ failure, ICU, all of that is possible. The vaccine is the main strategy for prevention. It's safe in people who've had a transplant. Obviously, if you've had a reaction to it, you got to really talk to your doc about that. But in general, it's been very safe, and so there's no reason not to do that. I hear a lot of reasons why not to get it, but there are some valid reasons. Obviously, if you had a reaction, if you're allergic to certain components of the vaccine, of course. But in general, it's safe and recommended for the majority of transplant recipients. This is the only slide I'm going to show you in this session about, again, keeping with the theme of trying to stay healthy and overall body and the kidney, is just in terms of cancer screening. This is really for the majority of us, whether we received it. There are some slight differences that I'll share with you in the afternoon for those of you that are going to join us. But the same things, mammograms, skin checks, especially. I'll dive in way deeper in terms of skin cancer, but that's going to be one of the main risks of cancer after transplant is the skin cancer, and how to go about that. Pap smears, mammograms for the guys, prostate checks, all that is still valid. Colon screening that actually kind of changed in the last year or so. Officially, it was 50 years in age and over for most of us, but now it's more recently now 45 years of age is being recommended, and more that's happening. There's something specific to transplant. It's called post-transplant lymphoproliferative disorder, or PTLD. I'll get into that this afternoon about a special type of like lymphoma after transplant. And I'll talk about kidney cancer in particular later this afternoon as well, because there is a higher risk of kidney cancer in those that have been on dialysis, especially those on long-term dialysis. So I'm going to keep kind of buzzing forward. I know we're running a little short of time, but I'll get back to the COVID vaccine near the end. Of course, all things these days is going to be COVID related, so I thought I would end that way. But some of the medicines that we give, and this shows you that we can make things worse. We're not trying to make it worse, but it happens. So those that are, you'll see on the left, tacrolimus, actually could really induce diabetes and high blood pressure, and mess with your lipids as well. So you're like, great, well, you know, why should I do that? Well, obviously, tacrolimus is probably the single most important medication in terms of an anti-rejection perspective. Steroids get a horrible rap. And I understand why, because back in the day, we used to use really high doses, really high. The main things that they do can raise your sugars and your blood pressure, cholesterol as well to a certain extent. All that kind of, you know, at the end, though, it leads to damage, you know, circulation damage, atherosclerosis, which is in the middle. Some other medicines way in the top, you'll notice cyclosporine, which was the mainstay in the 80s and 90s to a certain extent, still in use, although not as common. You'll see that it actually, messes with your cholesterol, your lipids, and high blood pressure. But you may notice that it does not, at least traditionally, raise your sugars. So when I see someone at the beginning, especially in the first couple months, who was having high sugars and they were not diabetic, or maybe they were borderline, or not really ever fully, identified as diabetic, I will switch, and personalize their medication from tacrolimus to cyclosporine, because I'm more afraid of the diabetes than maybe less afraid of the high blood pressure that I think I might be able to manage a little bit more easily. So that's a maneuver that we do use. It doesn't always work, but the earlier you recognize it and if it's safe to do, that's one of my favorite maneuvers to try to make things better. In that regard, steroids, I know this is always a topic that everybody loves to talk about. So steroid use is still out there. There are centers out there that don't use steroids after like the first week of transplant. There are. It's not the majority, but there are. But basically, like maybe 2/3 to 3/4 of centers do use them after 1 year. There is a risk, however, if you do go to a center that does not use steroids after the first week, there is a risk, a substantial risk, that you may end up being on them anyways later on due to a rejection episode. So that's the risk. That's the trade-off of those that want to come off of steroids. My approach has always been to try to get you down as quickly as possible to a low dose, hopefully within a month or so, to minimize the side effects. That's kind of our approach here, and a kind of a common approach in many places as well. But those are the evil steroids that everyone worries about. And I understand why, because historically they were super, super high doses. I'm going back to diabetes again, just because it's so important. It can really affect almost those that develop diabetes or after transplant. There's some data that suggests that the outcomes are almost just as bad as rejection. Like, everyone really worries about rejection, but even developing diabetes after transplant could also alter the course of your kidney. It could also affect longevity and overall happiness, if you will. So that's a big thing. Roughly, it's hard to say, but I saw a publication recently, maybe up to 20% of people can develop diabetes after transplant. There are some people more at risk than others, but I think something to look out for everyone. Okay, I'm going to briefly just talk about infections. This might be the only true slide on this. So, just to give you an idea, and I know it's kind of a busy slide, but bottom line, at the beginning, the most common infection that one might get is either a urine infection or maybe, I guess, a wound infection the first month, especially. But again, just looking out for those things. But thankfully, a lot of these things that I'm showing you are not that common. These are things that we think of, but I'm going to say the most common thing is a urine infection. Why? It's because maybe you had a bladder catheter when you had your transplant for maybe up to a week. There are other things that are involved with that. Maybe those of you that have been on dialysis a long time and didn't urinate for a few years, the bladder sometimes needs to kind of cleanse after a while. And so that's why the urine, I'd say, is number one. But these are all the things to look at. As I segue into this, and I guess thank you to Lori for bringing up this topic, because Lori is obviously, for those of you that know her, she's a famous animal lover, and actually I am too. I love pets as well. But a lot of people, I just showed you about infections, but all that previous slide that I showed you, having a pet does not really increase your risk for any of what I just showed you. It really doesn't. Now there's some common sense things that, and there's very little information about having pets after having a transplant. I've seen some extreme examples of people kind of taking that message of, like, pets and having a transplant and doing some extreme things that I would not recommend, such as getting rid of your animals. I don't generally recommend that. I've heard of some really extreme decisions being made because they thought they weren't supposed to have certain animals. Now, obviously, if you just had a transplant, probably not the best idea to get a brand new pet or animal at home, when you're recovering, especially certain, obviously it says if young or feral cats. I mean, I hope, people aren't doing that so early after transplant, especially the first 6 months as your immune system is probably at its lowest. Obviously, and I do have some people that have this backyard poultry. They raise chickens, they raise other animals. Again, I don't recommend them to sell the farm. I don't recommend them to move. I just recommend, maybe in that case, maybe not to handle at the beginning, just stay away, but, have someone else, handle the chickens out in the back. Please, don't handle certain things, common sense things, but please do not think of getting rid of your pets or your animals, because I think it does actually contribute to a positive experience over the long term to have, your friends and loved ones, including your furry friends, at home where they belong as well. So again, this is all I have on this topic. It's from a government website. I think it's also from the FDA as well, or no, the CDC. This might be from the CDC. There's not much data on there, but just some common sense stuff. All right, let's flip. I'm wrapping up. Let's flip over to the COVID vaccine. This is a little, things evolve so much that hopefully the data is even better. But the attitude towards the vaccine, I know there's a lot of controversy, and this is not meant to be political at all. But just the facts, at least so far from what we've seen this year, the vaccine does seem to help, people from getting really sick. In a transplant recipient, it seems that 2 doses is not enough, and I'll show you a couple of slides on that. There is data to show, thankfully, those of you that are on dialysis and have not had your transplant yet, that the vaccine is more effective if you receive it before the transplant than after the transplant, which is the case with many vaccines anyways. But this data is from about 3 months old. Well, this paper is from about 3 months old. The data is probably closer to probably 6 months old. But this was just added to from those that have received a transplant who were planning on getting the vaccine. And it depends on who was recommending it. If you're, the primary care, which I don't agree with. Obviously, if the primary care doc is saying, hey, it's a good idea, maybe 64% thought they would do it. If another transplant team member, maybe in the office, said, hey, you should do it, it rose up a little bit. And I guess if your transplant surgeon or one of your transplant physicians said it, it went a lot higher. You obviously would like to see, high numbers across the board, because especially now, it's been almost a year that it's been out there. It's been very safe in those that have had a transplant. This is the same publication. And you might remember at the very beginning, the studies from last year they actually excluded people who've had a transplant, right? They actually excluded them back then. And so a lot of people, and so on the left is people that were unaware of the exclusion. And they were like, maybe about half of them were open to the vaccine. And then once they were made aware that, hey, it was not specifically studied in those that received a transplant, then it plummeted even further. I'm hoping that over as the year has elapsed, those attitudes have changed. That's kind of what I'm sure maybe many of you struggled with that question of whether you should go for it or not. So that's hopefully many of you have elected to receive it. But again, so interestingly, this slide, the same paper, they talked about, people that live with you if you've had a transplant. So your household contacts of someone who had a transplant and whether they intended to receive a vaccine. And it's stratified on the left in blue if they live with someone that had a transplant, and then on the right in red that they did not live with someone that had a transplant. And basically, it's still pretty low. You think that they would hope that they would also protect themselves to protect their loved one who received a transplant. Again, this information was published about 3 months ago, and the data is probably closer to 5 to 6 months old. So hopefully, as more time has elapsed, these numbers have gone up over time. And this next quick study also came out earlier in the year. Actually, this was a survey at the beginning of the year. It was a survey of a dialysis cohort, a group of patients, 1,500 patients across the country. A little less than half were women, about 2/3 were non-Caucasian. And of all the responders, this one actually wasn't as bad. It was 20% were kind of not sure about it. And even back then, it was early days. It was January 8th to February 11th. That's when the questionnaires were given. But there were some trends. The younger people were more hesitant than those that were more mature. African-American patients were more hesitant. Native Americans as well. Women actually were a little bit more hesitant, at least in this early set of data back in earlier in the year. I mean, it's January, February seems like so long ago, at least in terms of COVID. There is a little bit more recent data that I'm going to show you, but actually we'll kind of get away from like whether whether one would want to accept the vaccine or not. Now let's show like how they responded for those that did kind of go for it. This was a small study at the beginning from France, and some of it may be surprising and unsettling, but I'll show you how it's evolved. But the good news is, if you're on dialysis, after the first dose is not that effective. But you see the second dose on the right, and about 89% response rate from an antibody perspective, and from a T cell perspective, 100%. But the antibody is what everyone focuses on. So that's about 88.9% responded. Unfortunately, in transplant, which is below, which is kind of the hand with the kidney, that's the transplant group, they barely responded to the first dose. And really the second dose, they had 17.8% response from an antibody perspective. Quite low. There's been different papers, and you'll see different rates, different numbers. I've seen higher actually. But this was the first idea that, hey, maybe there's something there. We need to kind of investigate whether 2 doses is enough, and other ways to approach this. This is a bit larger study that in particular studied what turns out to be the Pfizer vaccine in this country, the BNT 162b2. That's Pfizer. They studied about 80 dialysis patients, 75 transplant recipients, and 7 controls. And what they found is that they confirmed that in transplant, it's the antibody response is not great. It is better though in those that are on dialysis. Again, the recommendation, please receive, if you're thinking about it and you haven't done so, please do it before the transplant if you can. And those that may not respond as well, who are on dialysis, are above the age of 75, maybe not getting the best dialysis, and that did not respond to another prior vaccine in terms of the hepatitis B that many of you people get on dialysis. So the good news is that it's more effective in those that are on dialysis. The bad news is on transplant, it's not. So based with that information, and this is kind of what all the news has been, this is kind of, I'm about to wrap up. I have maybe one more slide. So basically, they knew that 2 wasn't enough. And this came out from New England Journal not that long ago, 100 patients in France. Bottom line is they felt that 3 doses was safe. And with the 3rd dose, the immune response is more robust and better. better in that regard. Although it's still not going to be like 100% or 90% that you're hearing from people that have not had a transplant. So unfortunately, stay tuned about, whether there's going to be more than 3. But definitely the third did help quite a bit. That's the good news. And this is basically just showing the same thing. So I won't, due to time, I'm just gonna wrap up. This is the last slide. Basically, I know it's kind of jumped around quite a little bit. The conclusions, at least, hopefully I've shown you. We start off at the very beginning with testing on just how to assess whether your kidney is healthy or not. Within that, there are new tests that are being introduced to monitor your transplant in what's considered a non-invasive way, which is nice without having to do an actual biopsy and poke you. That's always a good thing. Simple but important measures go a long way to ensure kidney health and overall health. And I showed you the data. It's actually right there. Exercise, better nutrition, and basically controlling what you can control. And for those of you that are smoking, please stop. Things like that. But I know it's not easy. Staying up to date with cancer screening, vaccines. I will talk more about cancer screening this afternoon. And then we wrapped up with the COVID vaccine. It does appear to be safe in transplant recipients. We know the third booster is needed, maybe more. It's hard to say, especially as we embark in our winter in the next couple months, hopefully not. But I do recommend for those of you that had a transplant to receive your third dose if you haven't done so already. I'm getting mine, I think, next week. So we'll kind of go from there. And with that, thanks very much. Appreciate it.
Hey, Dr. V, we have a couple questions I want to ask before we move on to the next speaker, and you have quite a few here. So the first one is, how much should you drink a day with a transplant? And, what about alcohol? You have any comments on alcohol? Can we have a drink? What's considered excessive?
Sure. The usual answer to fluid intake is always going to be roughly around 2 liters. That's always the generic answer. But some of it is, at first, I may ask you to drink a little less because the kidney at the very beginning may be in transition. It might take a few weeks for it to fully kick in and filter. So, but in general, 2 liters is a nice rough, basically that's like 4 bottles of water roughly. That's kind of the average, but in some people, they might require more, especially if maybe you're not feeling well and you're maybe have loose bowels, for a few days, please account for that because you could easily lose half a liter to a liter in your stool. On hot days in the summer, you could lose half a liter just by sweating, especially if you're exposed outside. But in general, day to day, I think roughly 2 liters is roughly right. As for alcohol, again, a while ago I said the answer is always no, just about to anything. But then people ask me later, and I'll be, in general, it's assuming things are okay, blood pressure. Now, alcohol can raise blood pressure a little bit. So assuming everything's kind of under control and it's a special occasion here and there, of course, people have a glass of wine to celebrate their transplant anniversary, maybe their wedding anniversary, their birthday, something. Of course, absolutely. I'm not, and we know that people do, enjoy that from time to time, and it's fine. Now, obviously, what's excessive, obviously, daily alcohol is not a good idea for anyone, right? Not a good idea, and really having more than maybe a couple drinks at a time is probably not a good idea either, ever, in general. So.
Oh, what about gardening?
I don't really have, the thing, and I'll share with you later, with gardening, I know people are worried about like maybe being like stuck with a thorn or a plant or anything in particular, but I'm more worried about the sun exposure. And we'll get into that, about how to protect yourself when that happens. But in gardening, I think in general is fine. With the soil, I know people, worry about that, but it doesn't really come into play.
And then there's a lot of questions, but we're going to kind of close with this one. What are the numbers that a transplant recipient should look at on their lab values? And, there was a question about what eGFR do you look at? And I'm just going to say mine's 98% right now. I'm bragging. Wow. That's pretty darn good, huh? I'm like, I want to plaster that one up.
Yeah.
But you want to close with that?
Yeah.
That would be awesome.
Yeah, that I'm glad you said. So first of all, just so you know, the lab does not know that you have one kidney. Okay, the lab assumes that you have two kidneys. So it's unfair to judge one kidney against what a standard is for two kidneys. I always say that. People always want to know what's my number, what's my number. And in general, my answer is like it's stable, or it's a little bit better, or that's what I worry about is when it deviates from what you're supposed to, where you've been before. That's my main concern. So, but GFRs really, again, living donors are going to offer you way better, you know, GFR. And I believe, Lori, yours was a living donor. Is that right?
Yes, it
Yeah.
was.
So again, that's great. And that's fantastic, actually. But basically, EGFRs, if you have a deceased donor, I would hope it's close to 50 plus, living donor 80 plus. Those are kind of rough, but it's not fair, really. Hopefully, your transplant center, they're going to get mad at me for saying that, but it all depends on where you've been, what's going on, who your donor was. Obviously, if you had a deceased donor and you waited 15 years for your kidney versus waiting 3 months for your living donor kidney, it's different. It does translate. So, but yes, I guess the GFR is one thing, but the trend is actually probably the most important and not necessarily the absolute number.
Well, thank you so much, Dr. V. You have a lot of questions. Come back to the session in the afternoon. I'm sure we can have time to wrap up some. Some of the questions that were asked, you really need to talk to your doctor about because they're specific. So shoot your transplant team an email. That's what they're there for, right?
Exactly. And as speaking of, I got to get back to the clinic.
All right. Thank you so much for your time.
Appreciate it. Thank you.
And a shout out to our corporate mission partners for making this happen.